Am I audible to everyone?
Yes, yes.
All right. Okay. So without much delay, I will start the presentation. So NEC is a topic that has been, previously spoken about, but I thought I'll give it a practical perspective for, the fellows and residents so that they can remember the evidence in an easy way and also look at some practical points that will help them for their routine practice. So the topic for today's discussion is evidence for prevention of NEC, practices and perspectives. And I'll try to take you through this presentation through a story about baby food and some bugs and how they help in preventing NEC. So coming to the first point before I get into a topic is this topic really relevant in current era 2022 NEC? How common is it? So it still remains a devastating diagnosis. Mortality rates described are anywhere between 20 to 40%, somewhere between 30%, 35%. And even in survivors, there are long-term concerns. So there is concerns of stricture, short bowel syndrome, and adverse neurodevelopmental outcomes. So it is shown to be an independent risk factor for adverse neurodevelopment. How common is it? So the incidence varies with the definition that they use. So some will use blood in stools as NEC, some will use a radiological criteria. So depending on the definition, the incidence may vary depending on the population. So if I say NEC in ELBW babies, it might be higher. In all VLBW babies, it is lower. All NICU admissions, it is very less. So it will depend on what population you are defining it and the setting. So is it a developed country, developing country, government hospital, private hospital? So a lot of factors vary as per the incidence. But looking at most of the Western data, the incidence varies anywhere between 6 to 10%, with some newer studies and quality improvement projects showing low rates even as 2 to 3%. So the incidence has been slowly coming down. As per the NICHD data, it was around 11%, but this is again old data, 2010 by Stoll et al. Korean Neonatal Network reported 6.4. The Vermont Oxford Network, which is considered a benchmark in 22 to 29 weekers, had an incidence of NEC 9%. Canadian Neonatal Network also 9%, and Spanish network around 8.8%. So, like I said, around 7% is what most reviews or meta-analysis would sort of cap it at. Have we improved in reducing NEC over the last few years? Yes, we have, but only a bit. So, what are the excuses we have that why we have not improved a lot in NEC reduction? One is our favorite excuse is that we have improved survival. So now we are saving smaller and smaller babies. So, how can we reduce NEC? 23 weekers, 24 weekers are surviving. There is no clear definition on NEC. So previously the definition of NEC was a little vague. So probably the, incidence was higher. Now we are taking only grade stage 2 and more NEC in our definition. We are excluding stage 1 NEC. So the definitions are different in different studies. In the olden times, it was the belt staging. Again, there was some subjective criteria, clinical criteria, radiographic criteria. And the gold standard, that was necrosis or presence of gangrene on surgery is not possible in a majority of cases because, that is an autopsy diagnosis. As we know, the pathophysiology of NEC is mainly having four factors. One is a vulnerable intestine, that is a premature sick baby. Next is a dysregulated microbiome. So exposure to antibiotics, delivery by C-section, being in the NICU, all this affects the microbiome. Intestinal ischemia, diving seal reflex is more in IUGR babies, babies with abnormal reversal of Doppler and bigger babies. And feeds, and especially formula feed, is one strong risk factor for NEC. So broadly, these four factors play an important role in increasing NEC. And when we talk about prevention of NEC, a load of things come to my mind. So, feeding regimes, human milk, decreasing empiric antibiotics, lactoferrin, colostrum, treating PDAs early, using a human milk based fortifier, prebiotics, probiotics, oxygen saturation. So, lot of associations are there with NEC. But how do I synthesize this evidence is what we are going to learn in this presentation. So the goal is always to have a zero NEC rate in your unit, especially for surgical NEC. So strategy one, the broad heading of strategy one is feeding strategies. So coming to feeding strategies, the most important is type of feed. So we know that there are three types of feed: mother's own milk, donor human milk, and formula milk. And most evidence suggests that it is beneficial in that order. So mother's own milk followed by donor human milk followed by formula milk. So when you look at studies comparing human milk versus preterm formula, how many RCTs or how much evidence would be there? We will look at that. Then we look at human milk dose. So, having higher amount of human milk and less amount of formula. So say if a baby is getting majority of human milk, more than 50% of the requirement as human milk versus only 20% requirement as human milk. So that is the other, outcome that can be measured. The third is that what if it is an exclusive human milk based diet, which means that even the fortifier you use is human milk based fortifier, the prolacta or the neolacta, whichever is available in your country. So that would be the third criteria. So coming or teasing out this evidence, human milk versus preterm formula. So it's very easy to remember. There has been a Cochrane review on this, but can you guess how many RCTs are there in a Cochrane review? Who do such a study that one group only gets preterm formula, one group only gets mother's milk? So is this sort of an RCT ethical in the current generation? No. So mother's own milk versus exclusive preterm formula, there is a meta-analysis of RCTs by Brown et al. In 2019. However, they included 0 trials. So there were no randomized trials naturally about human milk versus preterm formula. So that is a topic that is not ethical. But there are some observational cohort studies where probably they did not have mother's own milk, so they gave preterm formula, where mother's milk was not available. So there is evidence from observational studies. 9 studies are there, and they showed that there was definitely reduction in NEC where they used mother's milk or human milk. And 3,700 infants were enrolled. So there is good enough evidence from observational studies, and it is also common sense. So we don't need to explore this topic any further when there's human milk versus preterm formula. Then it is donor human milk. So say mother's own milk is not available, then is donor human milk better than formula for the remainder? So donor human milk versus formula, when MOM is mother's own milk is insufficient. So there is a dose effect, which means that human milk, mothers plus donor versus mother's milk plus preterm formula. So these studies are also a little few years old. So where the milk bank is not very strong, or they don't have enough milk, or say they want to do this study to rationalize that they want to make a milk bank, but in the current era, again, this study also would not be ethical. If you have a donor milk is better than formula also. So this study in 2016 by Debbie O'Connor showed a significant reduction in NEC, 1.7 versus 6.6. The early nutrition study was conducted in 2016 also. They did not show a reduction in NEC. However, they were really short of donor milk. So even in the intervention group where they used donor human milk, the babies got donor human milk only for 10 days. And they had a very, very good rate of mother's own milk rate. So which meant that both the groups, intervention and control group, 85 to 90% babies actually got a lot of mother's own milk. So the donor human milk dose was not sufficient to produce an impact. And again, a Cochrane meta-analysis in 2019 showed that there was increased NEC with formulas. So mother's own milk is the best. Donor human milk again reduces NEC compared to formula milk. What if the mother's own milk is 50%, 70%? So is there a dose dependent effect? Again, mostly from observational studies, there is a dose dependent effect that the more mother's milk you get, the less chances of the baby having NEC. And there are actually 2 RCTs saying that if the mother's own milk was more than 50% of the total requirement, which means majority of the feed as mother's own milk, it reduced NEC. So this is all about the type of feeding. The last point about the type of feeding was the exclusive human milk diet that I said. So what about human milk based fortifiers? In India also there is neolacta available. In the Western countries there is prolacta. So again, 3 studies are there, 3 big studies. Very easy to remember. The first study, which is the oldest study, was a company-sponsored study by Sullivan et al. But there was a big major flaw in that study. So what was the flaw? That one group in that study was mother's own milk with donor human milk and human milk fortifier. So this was the exclusive human milk based diet. And in the other group, what they did is that they gave mother's own milk. But when mother's own milk was not sufficient, they actually gave preterm formula. So they didn't give them donor human milk. And then they gave cow's milk fortifier. So there were two interventions actually in this study, which were, negative for the baby. They did show a reduction in NEC with the exclusive human milk based diet. However, it was not clear because this group also got preterm formula. So it was really not clear whether the benefit is due to human milk based fortifier or it was due to the preterm formula that the other milk got. So this study again didn't create a lot of hype because it was company funded and there was a major flaw. Another study 3 years later, what they did is they ethically sort of said that, okay, mothers who did not provide mother's own milk will get preterm formula because they again wanted to compare human milk fortifier. So this again showed a huge reduction in NEC, but there were two problems again in this study. One was the small sample size, which is 55, and the other was that a very high incidence of NEC. So 21% was the reported NEC rates. So there were a lot of questions raised about the high incidence of baseline NEC rates. The only study on human milk fortifier, which is non-funded, was done by the Canadian Neonatal Network. So Debbie O'Connor, again from Toronto, published this in JAMA 2018. And the non-funded study showed that human milk fortifier was actually not, did not show any reduction in NEC compared to mother's milk fortifier. So cow's milk fortifier or human milk fortifier, as long as you have donor bank and you have a milk bank, there was no significant reduction in NEC. So this study was actually done in Canada because Health Canada wanted to decide whether to, because it's a government funded system. So they have equity of healthcare. So they wanted to decide, should we, if it is really better, then we should have mother's milk based fortifier for all the preterm babies. So at least let us find out if it is beneficial or not. So after this study, they, disapproved the mother's milk fortifier and they are still using cow's milk fortifier, just like most other units across the world. So basically for type of feeding, the human milk based fortifier, there are two, meta-analysis. So we read the three RCTs that were done about mothers or human milk based fortifier. And it is interesting to read that there are two meta-analysis. The one meta-analysis by 2019 Cochrane group, they found that there was no reduction in NEC because they excluded the previous two studies, which I mentioned, due to poor quality. So they only included one RCT. And then there was one more meta-analysis by Grace et al. In 2020. They showed reduction in NEC because they included two studies. So they included the study by Sullivan et al. And also O'Connor et al. So it's also important that when you read a meta-analysis, you should know what they have included, how strict their criteria is, and what is their methodology. So just because a meta-analysis is published doesn't mean that it needs to be accurate. So this is again a very interesting, research from the research point also, that in 2 years, two meta-analysis published in good journals have a different outcome. Then coming to feeding, other, good feeding practices that can reduce NEC. The first heading was the type of milk, good practices that reduce NEC. And the top thing that comes is standardized feeding regime. So what does standardized feeding regime mean? That you should have a fixed plan when to start feeds, how to increase feeds in your unit, when to fortify, when to stop feeds, so all these things should be written down. So it is not actually, recommending whether you go fast or go slow. It is saying that whatever you do, just document it and do it consistently. That is a standardized feeding regime and that will reduce NEC for your unit. So again, it is a very cheap intervention. You don't have to do anything. You just have to make a policy for your unit. And there are more than, 15 studies with 18,000 infants that have shown that standardized feeding regime reduces NEC. This is despite the fact that the standardized feeding regime in many units were different. So in unit A, if they are increasing by 30-35 ml per kilo per day, or in unit B, if they are increasing feeds by 30 ml per kilo per day, as long as they have their own standard feeding regimes, NEC will come down. So this is the other important parameter from a good feeding practice that reduces NEC. Then there are some good feeding practices that do not statistically reduce NEC, but you still might do it because they are logical, they are sensible, and they improve your, improve other patient outcomes. So those are minimal enteral nutrition or trophic feeds. Again, you reach full feeds faster, but does not reduce NEC. Feed advancement. So again, if you go fast, which is 25 to 40 ml per kilo per day feeds, you don't decrease NEC, but you don't increase NEC. So these are good practices because your days on parental nutrition come down, your days on IV fluids come down without any increase in NEC. So even though you go faster, you don't increase NEC. So they are good feeding practices. Again, oral immune therapy or colostrum is popular and more evidence is coming towards it. It is shown to reduce VAP rates, but there is no significant impact on NEC yet. Fortification practices like fortifying feeds early again does not increase your NEC rates. So these are all general good feeding practices that we follow without a statistically significant increase or decrease in NEC rates. So when you use MEN or trophic feeds, you achieve full feeds faster. Again, there are 9 trials with 750 infants. It should be introduced early. So when you say MEN, it should be introduced within 24 hours or at least 48 hours. And there is no role for delaying feeds beyond 72 hours, even for babies with abnormal Doppler. And you don't need to keep giving MEN for many days. So you can give MEN for 1-2 days and start advancing if things are okay. Feed advancement we discussed. It will help you achieve full feeds faster without increase in NEC. What is fast, what is slow? Again, the Cochrane reviews caps it at 24. So less than 24 ml per kilo per day is slow. 25 to 40 is fast. So again, that has shown that faster advancement does not increase NEC. Or if you want to interpret it, you can say that if you advance it slowly, you are not decreasing NEC. So then why to go slow? There was a network meta-analysis again by V. Raghavan et al. In 2021, and he classified the feed advancement rates into 3. So less than 20, 20 to 30, and more than 30. So he found that early advancement of feeds with large volume will increase NEC stage 2. So he says that early initiation with moderate advancement, which is 20 to 30 ml per kilo per day, may be a better strategy, but the class of evidence is very low. So again, this is a network meta-analysis, not an individual study. So the evidence has to be taken with a pinch of salt. Oral immune therapy or colostrum, it reduces VAP, days to full feed is reduced. And again, it's become more and more popular. It's easy to do, it's cheap. And a meta-analysis has been published in 2020, which shows a possible reduction in NEC with a borderline odds ratio. So 0.51, but if you look at the upper confidence interval, it's 0.99. So it is very close to 1. But again, it has other benefits. So oral immune therapy is definitely a practice that can be implemented. So does fortification increase NEC? No. So there is no effect of fortification, whether you use cow's milk fortification, whatever fortification on NEC. So multi-nutrient fortification, whether you use standard fortification, targeted, it is fine. You can start fortification early or delayed. So you can start it as early as 50 to 70 ml per kilo per day, or you can start it at 120, 140 like tradition. You can use a liquid fortifier, or you can use a powder fortifier. So there are small RCTs, and again, there is no effect on NEC. There is a recent study from AIMS that got published in JAMA that you can use a preterm formula also as a fortifier, and that also did not increase NEC. So again, these are some practices that you can follow without a increase in NEC risk. So the first heading was all about strategy, was all about feeding. The next heading is going to be about the bugs, which is the probiotics. So if you look at probiotics from a big camera, from a big lens, there is evidence from 12,000 premature infants as RCT. So such a huge pool of evidence, on probiotics and NEC. In the last 3 years, there have been 3 network meta-analysis, 5 systematic reviews on probiotic use. So there is so much data that, people have interpreted it in different ways. There are position statements which are very clear by AAP and ESPGHAN. So both American bodies and the European nutrition bodies have guidelines on should we use or not. So finally, it's up to us. How do we synthesize? How do we interpret? Should we follow like what the Australians do, or should we be more cautious like in UK? So let us individually sort of go through the evidence and then decide for ourselves what is best. So broad picture, like I said, of probiotics is that 12,000 neonates have been enrolled. It reduces mortality, NEC stage 2 or more, and late onset sepsis in premature babies. But when you look at the evidence in more detail, what are the problems? That extremely preterm babies, if you include that is less than 28 weeks, and if you look only at RCT data. So if I'm going to do a meta-analysis and I say that I want to do a meta-analysis of RCTs only, and only high quality RCTs, including only extremely preterm babies, then the statistically significant reduction does not remain statistically significant. Again, the evidence of neurodevelopment in extremely preterm babies is not strong. For other babies, we have some data on long-term development also. The main problem, so the main problem basically that everybody, complains for probiotics is the quality control. So probiotics is basically a food regulated thing in US. So it is not regulated by FDA. So there is a huge problem in terms of, what, who is regulating. It's not a pharmacy product. So whether they are saying they are putting 5 billion bacteria, but who is checking that? Who is, doing a quality check? Is it sterile? All that is a little bit dicey. So that is why US FDA and, other bodies are very hesitant in approving probiotics. And then the major problem was the PIPS trial. So this was the largest RCT, included small babies, conducted in UK, multi-center, 1315 infants for an RCT is very good numbers. And that did not favor treatment. So they found that use of probiotics, was equal. So the RR was 0.93. But whether it was due to an effective strain, so they used Bifidobacterium breve. If they use the low dose, was there cross contamination? These are speculations. But however, whatever it is, the results were non-significant. So after this study, again, people, bodies, Espegan are like a little hesitant that should we really use it, because the problem of NEC is in less than 28 weekers. If the evidence is not strong in less than 28 weekers, then why to use it in that high risk group? So what about the meta-analysis of RCTs? So 56 trials are there. So more than 10,000 infants. Majority trials are small with poor methodology. Did show a significantly reduction in NEC. After doing sensitivity analysis and removing the low bias trials, also there was a reduction in NEC. So it does show reduction in NEC for sure, based on whatever data has been published as per the Cochrane meta-analysis. And then the network meta-analysis in 2021, which showed the strain-specific reduction, showed that Lactobacillus acidophilus was probably one of the most effective strains, and Bifidobacterium lactis again, especially if used with human milk, and Lactobacillus rhamni, rutri, and multigenous species were good. And again in 2020, there are, recently there have been 3 more systematic reviews. They have shown that combination is preferred to a single strain. So Bifidobacterium plus Lactobacillus, or Lactobacillus with a prebiotic. What about the generalizability? So are these studies from developing countries and they can't be used in developed countries, or vice versa? So they are pretty generalizable. So in low middle income countries, there was a systematic review in 17, which again showed a reduction in NEC. And recently there has been a meta-analysis of probiotic use only in India. So only Indian studies in 2020 included 9 RCTs, and that also showed a reduction in NEC. So especially for our setup, it is very, very useful to use probiotics if the right product is available. So this was all the RCT data. What about meta-analysis of observational studies? Again, in 2016, there has been a meta-analysis. More than 10,000 neonates also enrolled in, observational studies. Again, showed a reduction in NEC. And the effect size of 0.55, that is almost a 45 to 50% reduction, is similar that was seen for RCT data. What about prebiotics and synbiotics? So prebiotic is a substrate that is effectively utilized by the host microorganism and specifically stimulates the growth of beneficial microbes. Synbiotic is a mixture of live organism and a substrate that enhances the growth of excuse me, growth of host microorganisms. So again, use of prebiotic, synbiotic along with the probiotic has been published. So prebiotic alone, again, the Elfin study for lactoferrin did not show any difference in NEC. Synbiotic, which means that use of both, again 2015, 2009, there have been a few studies, and a pre-pro study by Nandini et al. In 2016, they have shown some reduction in NEC. The overall pooling of data meta-analysis shows that there is still low quality evidence that shows that a lactoferrin plus probiotic may reduce NEC. So there is some role for prebiotic and probiotic combination. However, the quality of evidence is not strong. So this is again not a routine recommendation to use prebiotics along with probiotics. So after all this evidence, there has been two recent position statements, like I said, by AAP and Espegan. So let us just see what they, after reading through all the data, all the evidence that we have presented, what is their final perspective. So AAP in 2021 has said that lack of FDA grade products, which is quality mediated. There have been callbacks for contamination. So they say that they are worried to use probiotics, and they say that routine use of probiotics is not recommended, and especially in ELBW infants. Now ELBW infants are the ones who need probiotics the most, so they are not recommending. So obviously a lot of units in the US become a little hesitant to use it. ESPEGAN, which is the European body 2020 recommendation, says that there is a conditional recommendation for the use of Lactobacillus rhamnosus GG or combination of bifidobacterium, infantis, lactis, thermophilus. However, they say that the optimal start of treatment total duration is not known. Again, they say that probiotics are loosely regulated and product safety and quality is a concern. So they have suggested that you may use conditionally, but with a lot of caution. So not again very clear despite huge amount of evidence about probiotic use. So coming to antenatal prevention strategies, again, what about antenatal steroids? So we know that antenatal steroids are standard of care. The 2017 review by Roberts et al. Showed that apart from the routine benefits of antenatal steroids, that is mortality, IVH, it reduces NEC. However, when they removed older data, when they had a recent updated Cochrane meta-analysis in 2020, the reduction in NEC was not significant. So again, antenatal steroids is standard of care, beneficial, lot of proven benefits. But per se for NEC, if you take only high quality studies, it is not very strong evidence. But that doesn't change our practice because the benefits of antenatal steroids are multifold. What about antenatal steroids for PROM? So in 2013, Cochrane again said that for PROM, if you use co-amoxiclav antibiotic for the mother, the preterm baby had an increased risk of NEC. So again, this is not a choice of antibiotic that we use for PROM. What about treatment for PDA? So if we treat PDA early, will we reduce NEC? So ibuprofen versus indomethacin, IV versus oral, lot of evidence again. The Cochrane meta-analysis said that reduction in NEC with ibuprofen use. However, with indomethacin prophylaxis, there was no reduction in NEC. So again, ibuprofen theoretically has lesser effect on splanchnic circulation, renal circulation, so it is safer. But if you see the effect size, the significance was not much. So you again won't close your PDA hoping that your NEC will come down. You will close your PDA based on hemodynamic parameters and the baby's clinical status. Delayed cord clamping, again there is weak evidence. So this systematic review in 2019 by Bhavan Garg also showed that use of delayed cord clamping reduced NEC. Again, the effect size was not very significant, 0.37 to 0.94. So wide confidence intervals. What about your oxygenation? So oxygen target saturation or oxygen targeting studies are there. So the meta-analysis of the prospectively planned oxygen trials, more than 4,500 infants have been involved, and they have shown that babies with lower oxygen target, 85 to 89%, versus higher, which is 91 to 95. There was a higher NEC rate in the lower SpO2 target group. So the lower group had higher mortality and higher NEC. So again, keeping a very, very low saturation target group is probably not ideal from NEC perspective. What about antibiotic use? So prolonged early antibiotics exposure. So if the baby is at risk of infection, you take culture, you give for 3 days till the cultures come negative. Some people give for 5 days. Some people give prophylactic antibiotics for 7 days. So Again, there is older data. NICHD 2009 data showed that there was 53% of babies who were exposed to antibiotics, without a culture positive thing, early onset, and there was increase in NEC in the groups exposed to antibiotics. However, their own updated data in 2019 said that the antibiotic usage also was coming down a little, and there was no increase in NEC based on their data. Again, Canadian Neonatal Network also did not show increase in NEC rates and a 42% exposure. The Neo-Nutrinet cohort again said that the infants who did not receive antibiotics actually had higher NEC. So this was paradoxical to what we typically think. So broadly, if you synthesize everything, does antibiotic use, really cause NEC? It is not clear, but antibiotic use is not good because it, unnecessary antibiotic use increases resistance in your own unit. It, changes the baby's microbiome. It is usually overall not a good practice to use unnecessary or prophylactic antibiotics. What about postnatal practices? So, which no or little evidence for intervention. So there is weak evidence that early low dose erythropoietin, reduces NEC. So moderate to weak quality evidence favors use of early low dose erythropoietin in small babies. Lot of studies have been published on liberal versus restrictive transfusion thresholds. So whether to transfuse early, whether to transfuse late. So there are top study, ETNO. So many studies have come, almost 5 RCTs are there. Again, there is no benefit saying that, the thought is that if you restrict transfusion, hypoxia will lead to intestinal ischemia, inflammation. But in terms of the pooling of data, that is not shown to be true. The other thought is that is it anemia that causes, NEC inflammation, or is it transfusion? So TRANEC, which is transfusion associated NEC, is a common association. Many case series are reported, but the cause effect proof has not been yet made. Recent studies actually say that it's probably anemia that causes low grade inflammation in the intestine. So there are studies measuring stool inflammatory markers, and they found that babies who are actually anemic have higher markers of stool inflammatory markers in the stool. So they are actually suggesting that having the baby anemic is probably more of a problem than giving the baby a transfusion. Withholding feeds during PRBC transfusion. So again, lot of variety in practice. So a lot of units withhold feeds for 4 hours, 6 hours, 12 hours. Some units continue to feed. Some people have seen that while feeding NEC happens. So again, there is insufficient data to favor whether you need to hold feeds or continue feeds. But there is a recent study, duration of feeds. So feed the DUR study, which was published in 2020, again said that it is okay to feed. So it was a 3-arm trial. So there were 3 groups, where they had one was NBM, one was one feed strategy, the other was slightly higher, 120 ml per kilo versus full feeds versus no feeds. So they didn't find a difference in NEC amongst the 3 groups. So they say that you can feed. But again, this is a very practice-based thing. Omega-3 long chain polyunsaturated fatty acids, there is again some evidence building, but no conclusive evidence that it decreases NEC. Use of enteral antibiotics like valamycin, that you give enterally. There are some very old studies that say that it could possibly reduce NEC, but it is not a standard practice anymore. So that is something that is not routinely practiced. So these were ones that are the evidence. The postnatal practices where there is some interest but no evidence for reduction in NEC. Ongoing trials that are going on for NEC is, again, OIT is very popular. A lot of studies are still going on oral immune therapy or colostrum because it is safe, natural, and cheap. Arginine, again, thought to be protective. DHA can reduce NEC. Stem cell studies are going on rodent models, and the connection study for lactobacillus reuteri. So probiotics is something that is still being explored. Despite some people will feel that already 12,000 babies are there, what is it going to change? Why bother study? But again, finding the right dose, right strain, right population, very small babies, I think there is still some role in doing a trial for probiotics. So this was all about the evidence. Then when looking at acceptance, so worldwide, when we look at practices, how do people interpret this evidence, and how do they practice? So human milk is the most accepted intervention for reducing NEC. So mother's own milk followed by donor milk. No controversy, logical, simple, not to, think too much. Good feeding practice is the second most accepted strategy. So like I said, having a standardized feeding regime, using men, advancing feeds in a standard way. So all of that is again very well expanded, and most good units will have their own feeding policy. Probiotics, despite the huge amount of evidence, lot of surveys in the US have shown that only 55-60% units use probiotics. After the PIP trial, UK and many centers in UK have reduced probiotic use. Canada only approved probiotics in 2016-17. So I think it is slowly catching up, building up based on the availability, ease of availability and experience. But probiotics is the third popular strategy to reduce NEC. After that, antenatal steroids again is standard of care, and the based on evidence and everything, it is good. Decreasing empirical antibiotics use or prophylactic antibiotic use is again a good practice, but the evidence is for NEC is a little weak. Maintaining perfusion, oxygenation, again common sense and standard of care, but from NEC reduction, the evidence is not direct because those were not the direct outcomes for that. And then comes all the other things like oral immune therapy, erythropoietin, and all the other things I've talked about. So this is how the world has sort of taken over in terms of adapting these evidence of NEC prevention strategies. So why can't there be a study with NEC as the primary outcome? Is it possible to do now? So in our unit, or when I think of all the other units that I have worked in, it doesn't seem feasible because the incidence of NEC is very low. So if I want to reduce NEC from 6% to 3%, I would need a sample size of 1,000. So because the NEC rates have come down with good practice, having a study with NEC as the primary outcome is no more feasible. So most studies use a composite outcome like death or NEC, or NEC or late onset sepsis. So it is unlikely that we will get more robust evidence. Although we like more evidence, it is unlikely that we will get more robust evidence on NEC alone as the primary outcome. I think a lot of evidence that will come will again be as secondary evidence, where NEC is your secondary outcome because it's an important outcome. Again, there should be equipoise that whether the intervention is beneficial or not. If you think intervention is beneficial, then you can't do a study. So RCTs probably are less likely to come. So I think it is best that we synthesize the evidence that we already have and use it. So this study is a very, this slide is a very popular slide from,